Thank you, Piyush. Can I have the first? So the topic is AIH in children. How does it differ from adults? And we have already heard a lot about the adult autoimmune hepatitis. So the disease spectrum in children is ranging from autoimmune hepatitis, which could be of various types, fulminant, classical, seronegative, de novo AIH after transplant, and recurrent AIH after transplant. Then amongst the overlap, we have the overlap of autoimmune sclerosing cholangitis. And then we have sclerosing cholangitis, which again could be primary, secondary, and start also going on to neonatal sclerosing cholangitis, which is a genetic condition associated with DC-DC2 mutations. So how common it is? The prevalence of autoimmune hepatitis is much higher in adults as compared to children. But still, the rates in children have gone up, whether it is because of a true increase or whether it is because of a better awareness, we do not know. But as a proportion of etiology of CLD, AILD is perhaps more common in children. It accounts for about 11 to 20% of all chronic liver disease in children as compared to adults, where HBV, C, and alcohol perhaps take a greater share. So how frequent are these conditions? This is a population-based study, and you can see that amongst these three conditions, autoimmune hepatitis is most common, followed by PHC, followed by autoimmune sclerosing cholangitis, and this is in children. So the first difference is that when we ask for testing for serology in children, we ask for ANA, ASMA, and LKM, in contrast to adults where the first-line antibody is usually ANA and SMA. This is because the type 2 LKM-associated AILD is seen in about 1/3 of children, in contrast to only 2% or 5% of adults. The second difference is that when we are asking for serology, the autoantibodies in children are present in a much lower dilution. So if you ask for a cutoff of 1:40, it will come as negative and you will say there is no autoimmune liver disease. So you have to ask for a lower dilution of 1:20 for ANA, SMA and 1:10 for LKM. And this is important because the type 2 autoimmune hepatitis, that is the LKM positivity, is seen in younger children, more often associated with an acute liver failure presentation, and also seen in about 20% of the abscess syndrome, where the child will present with polyendotrinopathy, candidiasis, and ectodermal dystrophy. So you need to be aware of these conditions. Second, the overlap, or what is known as the AHC, is seen only with type 1. It is extremely, extremely rare to have an overlap syndrome with type 2 disease in children. When we score or when we diagnose autoimmune hepatitis, we all know that we have to exclude the other conditions. We need to have typical histopathology along with autoantibodies and raised IgG. And then there are various scoring systems. The first scoring system which was given was in 1999. And this has problems when you adapt it to children. Because number one, the autoantibody cutoffs are higher. Number two, their AMA positivity scoring is given, which is not seen in children. There are points for alcohol. And we all know that alphas cannot be used in children because of the growth. So we have to replace it by GGT. And again, there is no differentiation between AIH and AHC. But this score has been applied in children, and it has been shown that it is more useful if you have a child with atypical presentation, and if you apply it post-therapy where you get the advantage of improvement after immunosuppression. The simplified score again has got the problem of serology, but this is simpler to apply and it has been used more often and validated in children, but it has the problem that it will be overlooking or missing the atypical cases. And so if you have an atypical presentation, it is better to apply the older score rather than the simplified score. And then we have a revised pediatric criteria for diagnosing of AIH and AHC, where we have given points for both AIH and AHC. This has been given recently in 2018, and it needs validation because here they have asked for doing a cholangiography at diagnosis in all children with suspected autoimmune hepatitis. And the problem here becomes is that if the cholangiography is abnormal, which I would be coming to due to presence of just cirrhosis, where they may have milder degree of changes, we will be giving negative points and the diagnosis of AIH may be missed. And similarly, it will miss the small duct PHC and not pick up these overlap cases. But this is a study from ILBS where they have used all three scoring systems and they have shown that all three of them are comparing equally for the diagnosis of autoimmune hepatitis. So you can use any of the three, but they have their own limitations and you should use the appropriate score in the right setting. Now going on to overlap. The overlap in PBC and AIH is a disease of adults. We don't see it in children. It's very, very rare. But the overlap of AIH and PHC, which we call as AHC, is much more common in children. And we can see that amongst the different pediatric studies, anywhere from 10 to 50% of the patients with autoimmune hepatitis have this overlap syndrome as compared to adults. And this may be present either at diagnosis or it may appear even later on, and therefore, and because it has got implications for therapy, we need to have a high index of suspicion in children. So when we do a biliary imaging to diagnose AHC in children is a question which has still not been answered. Should we do it at diagnosis as a screening or should we do it in selective cases? If they have a biochemical feature of cholestasis like your GGT is very high, if they have biliary changes, if they are not responding to your standard immunosuppression, or if they have a concomitant IBD, or should we be doing it across the board? So the earlier consensus, the ASLD guidelines said that all children with AIH and only specific adults should undergo cholangiographic studies to exclude PHC. But the recent guidelines favor selective screening and it does not give separate recommendations for children. So let us look at it more deeply. What are the clues to suspect an autoimmune sclerosing cholangitis? As contrast to a patient who has got an autoimmune hepatitis. So the O2PT, obviously, this is more of cholestasis, so they are less raised. But the gamma GT obviously will be more raised in autoimmune sclerosing cholangitis. The female predominance is more in autoimmune hepatitis. It's 50% males in autoimmune sclerosing cholangitis. The overlap autoimmune sclerosing cholangitis has more of IBD and it is rarely LKM positive, but more likely to be ANCA positive. So if you have a male who's got an associated ulcerative colitis and has got a high GGT, the index of suspicion for autoimmune sclerosing cholangitis should go up. But none of these criteria are diagnostic. Then going to the biliary changes. The biliary changes again are not classical or isolated to overlap syndrome. These are two very good studies which have shown that mild biliary histological changes ranging from ductular proliferation to bile duct injury are seen in 20 to 40% of AIH. But therefore, it should not be taken as a negative pointer towards a diagnosis of AIH. This is a very good study which has come from Italy, where they have typically looked at the biliary changes in the form of inflammatory changes, ductular reaction, periductular fibrosis, and they have said that these were equally common in both these groups of AIH versus AHC. And therefore, they have said that histopathology alone will not be able to differentiate between these two groups. And cholangiogram remains the only effective tool if you have to differentiate between AIH and AHC in children. But still, you need more data because maybe it's a spectrum with more polystatic injury in sclerosing cholangitis and more hepatic injury in AIH. Then we have caution while we are interpreting cholangiography, because this is a cholangiogram MRCP of a patient who had HCV-related cirrhosis. So in any cirrhosis, there can be a peripheral pruning of the peripheral bile ducts, and this can be falsely represented as taken of sclerosing cholangitis. And this is what we had shown in a study from our center also, that nearly 1/4 of the patients with autoimmune hepatitis had these milder changes, which are actually not classical of an overlap syndrome, but were just secondary to cirrhosis. And when we took cirrhosis of other etiologies, these changes were similarly present. So it's important to differentiate these changes from true sclerosing cholangitis, and we need an expert radiologist for diagnosis of this. Then going to the one thing which is NAFLD. In adults, histological changes of NAFLD are seen in around 30% of AIH patients. And this can concurrent this can be affecting the response to therapy. But in children, again, it is much less common. Only 0 to 9% of AILD children have been found to have associated NAFLD. They may have falsely positive ANA and SMA, but they will never have LKM positivity, and their IgG is also raised in only about 1 in 4. So you need to suspect, but it is much less common as compared to adults. For treatment, AIH in children is more aggressive. Anywhere up to 80% of our children will have cirrhosis at diagnosis. And therefore, from the very beginning, we have been saying that all pediatric autoimmune liver disease deserves a trial of immunosuppression rather than these selective criteria for treatment which have been provocated or which have been recommended by the earlier EASL guidelines, British guidelines. But now in 2020, it is said that all patients with active disease, even adults, should be treated. So it's basically in adults, there are still some selection options, whereas for children, we would say treat all children who have autoimmune liver disease. Now, budesonide is recommended, as we heard Sami telling, as a first-line therapy, but we are not yet there as far as children are concerned. The evidence in children for favor of budesonide is much less as compared to adults. There is only one study where they have shown that the remission rates were much poorer, to the tune of about 16%, and also with prednisolone as up to 15%. There were similar doses given for the steroid side effects were similar, except for the fact that the children who were given budesonide has got a lesser weight gain. So we need more studies because this study has got a lot of limitations, and we cannot, as of today, recommend budesonide in children, except for a very selective group. In adults, the 5 studies and the meta-analysis favored budesonide in non-cirrhotic. But again, there is a recent trial which has been published 2023 in hepatology, and it very clearly shows that budesonide is to be used only in milder disease where they have the transaminases not more than 2 to 3 times raised. So we still need more data before we start taking budesonide to be comparable to prednisolone for the treatment, especially in children. Cessation of treatment, as has been already recommended, in children, a liver biopsy is a must, 100% requirement before we stop therapy. They have to be in remission, biochemical remission for 2 to 3 years. We have to do a biopsy. We have to show that there is no activity. Only then we can consider stoppage of therapy. Whereas in adults, the biopsy is optional. You may use fibroscan, show that it has come down. But for children, we cannot do this. And we never stop therapy during puberty. So you need to take account of the growth spurt. You need to take account of the pubertal status before you start thinking that you can withdraw and stop therapy in children. It is never to be done in LKM positive or type 2 because they are going to come back 100% to you with active disease. And it is only in 1 in 5 children with type 1 that you would be able to successfully stop the therapy with type 1 disease. So in therapy and follow-up, when we are monitoring these children, we need growth monitoring. We need to modify the maintenance of steroid versus ASA alone as per the growth condition. There are lesser concerns of associated comorbidities in children. They have good compliance, especially when they have parents to look after. But as soon as they become adolescent, the compliance becomes an issue. And so you need to be more vigilant. Bone densitometry and poor bone health is more of a problem with older people, especially women. In children, DEXA is not routinely recommended. And similarly, ferritin as a predictor of response has not been shown to be operating in children till now. So to conclude, I would like to say that autoimmune liver disease in children is more aggressive than adults. Diagnosis requires autoantibody testing in correct dilution of 1:20 and 1:10 for LKM. Type 2 has got about 1 in 4 children will have type 2 disease. It is unique characteristics. It's uncommon in adults. Majority of the children, including those with cirrhosis, will show a response to therapy, even if they are decompensated, and they should be considered for therapy. AIH PBC is uncommon, rare in children, but AHC is much more common as compared to adults. We need to have a high index of suspicion and do a biliary imaging, which should be again interpreted with caution in differentiating between cirrhosis versus changes of sclerosing cholangitis. The role of budesonide in children as an induction therapy is limited. It needs more studies. Liver biopsy mandatory before stopping therapy. Therapy stopping should never be done in the pubertal growth spurt and in type 2 disease. And proper nutrition and vaccination is essential in children for a good outcome. Thank you very much.